happy to proceed. Welcome back. I'll just repeat because I think the recording wasn't started yet. From lunch, we are now going to move into the session on voting questions. We do have a lot, but we want to have a robust conversation. They actually extended the time a little bit to make sure that we can do that. We want to have a robust conversation and also make sure to invite a lot of our experts who are here today, different types of experts to weigh in on the questions as well as hear from the research team led by Dr. Wren. So we will, Maddie, do you want to test the Slido, the voting software? Okay, I think no, because we tested it at the beginning. Thank you. So why don't so I all of the questions in this session, it's very important that I make this point about 2026. This is not a question about December of 2020. This is a question of the current state of people in the United States, with all the nuance that we've talked about, the different variants, the fact that people have been vaccinated and infected before. So that is the patient population that is referent to all these questions. Um, could I have the question up, please? So the first question, what I'm going to do is I'm going to go through three questions. We'll then hear from Dr. Rind, who can remind us the ICER report's evidence rating. We'll have some time for discussion, debate, and input from specialists, and then proceed to the vote. But we think batching it that way might be more efficient. So the first three questions are there particular obligations because of COVID-19 severity and current levels of unmet need that we should consider in our value assessment? Two, are there particular obligations because COVID-19 disproportionately affects those from a racial or ethnic group that have not been equitably served by the healthcare system? And three, apart from issues around disease severity or unmet needs, are there other things um, uh, unmet need in race and ethnicity? Are there other particular obligations that we should be considering? So David, maybe you could start by just reminding us your findings.
Sure. Thanks, Jason. For the first one, and by the way, this is in table 15 in the evidence summary for the CEPAC. We didn't really think that this one was relevant to the vaccines. Vaccines for COVID-19 have been available for 5 years now, and so we didn't have a lot to say on question one. On question two and question three, as we've discussed, COVID-19 disproportionately affected Black Americans and as well as Native American, American Indian, Alaskan Natives. The HIDE calculation that we do looking at the relative benefits that would be accrued, 1.35 in Black Americans and 1.11, which is a fairly small number in American Indian and Alaskan Natives. But those are groups that have not generally been viewed as equitably served and were at increased risk, at least early in the pandemic. And then in terms of other, as we discussed some, including in response to comments, many frontline workers were from groups of lower socioeconomic status. Lower socioeconomic status is clearly associated with more severe COVID early on. And so that's a group that may not have been served equitably by the healthcare system, is at increased risk. And so you might consider whether you want to vote on other as other issues, and you may have other issues beyond that you want to talk about.
Maybe with that, do any of the experts, we have patient experts, we have content expertise, clinical experts, I can see all four back rejoined our session. Does anyone want to weigh in on any of these issues? I see a hand up. Yes, Dr. Escontreras.
Yes, although I think the argument in terms of Black Americans and also American Indians as specific racial ethnic groups, I think we need to consider what other racial ethnic groups are appropriate to consider, not just beyond that. There are other racial ethnic groups that traditionally do not access healthcare in the same way. And I think there was earlier a question as well as long-term care facilities. We know that Black Americans are disproportionately impacted, but then that also leaves others who are not seeking care. So I'm just thinking about or immigrant communities, those of Hispanic Latino communities. So I think that that's a special consideration. And then to the third question, probably also we should take into consideration caregiver perspectives. I think that's also a wild community, specifically thinking of those who have been assisting those impacted by COVID-19. So those are probably some considerations that I would take into account.
Thank you.
I just comment, we'll have a chance to vote on caregivers in an additional question later on. So,
Excellent.
so depending on how you're thinking about that, it probably doesn't fit best here.
Perfect.
Thank you, but we will come back to it as reference. Jason.
Yeah, I'll just note briefly, piggybacking on David's point about disparities in COVID-19 outcomes. Perhaps not surprisingly, we've seen the same disparities in COVID-19 vaccination coverage since the start of the pandemic, continuing into the most recent season. Even as vaccination rates overall have declined, we continue to see those disparities in uptake by race, ethnicity, socioeconomic status, and so on. And all of those efforts that were really prioritized in the early days of the pandemic to address some of those structural barriers. May have made a bit of a dent, but that story remains as well in terms of who's getting the vaccine, how the vaccine's being reached or understood, and all those issues as well on that side of things as well.
And Jason, do you mind just summarizing what you mean? What are the disparities that we're still seeing? Like
just lower rates. I mean, if we just look across, race and ethnicity, we continue to see decrements in coverage across either poverty status, across whites versus Hispanic, African American,
yeah.
Asian. So those patterns, and they're true for most vaccines, notwithstanding the financial programs that try to at least reduce but not eliminate the barriers of cost. But clearly, in terms of access, communication, hesitancy, we see patterns that clearly are disproportionately creating barriers or impediments to vaccination among non-white groups and low-income populations in particular.
Dr. Schwartz, I'm assuming also in geographical location, correct? I would think we could throw that in there.
Absolutely. It's a rural, urban. Yes, I mean, you can slice it in many different ways, but there are clearly patterns here in COVID. I don't want to suggest as an outlier, but we see this across our widely recommended vaccines.
Other comments from the experts or things that the CEPAC want to say to sort of influence, because you can influence the rest of our votes by things that you might want to say now. Professor Vale.
Thanks. For number 3, one other thing that I'm considering, and I don't know of any new evidence, so I'm sort of building on older evidence, but we do know that people with substance use disorders have higher rates of COVID infection, as well as much higher rates of COVID-related hospitalizations. So that's another group that I think about as I think about inequities and disparities in care.
Thank you. Dr. Winston.
With regard to the third question, knowing that we have not much evidence about transmissibility, we still know that COVID-19 illness is made less severe by vaccine. And so the frontline workers that include healthcare workers is, I think, an additional obligation for us when we're thinking about implementation of policy. And regardless of risk, the healthcare system wouldn't be able to sustain a big loss. And so I think that's an additional obligation for us to consider.
Other comments or questions from anyone? Okay, with that, let's proceed to voting on questions 1 through... Oh, Dr. Gold, sorry.
Yeah, I just want to sort of underscore what was just said. Besides frontline healthcare workers, I'm concerned about people who, by necessity, their jobs put them in touch with the public with very little protection. And that would be, transportation workers and grocery store people. And, I am concerned that while the evidence rating is okay for adults and the general population, I could imagine in a policy situation that people would say, well, let's not worry about those folks, and that they wouldn't necessarily be taken out for consideration for insurance coverage. And I just would hope that whatever we do in the report, we would be able to say that this could be a real issue for folks who don't have other kinds of protections and whose insurance may be poor, particularly if these are not covered by insurance.
Other comments or questions from anyone on these topics, on any one of these questions? Professor Conti?
Thank you. I agree with Professor Gold and would add to that special considerations um, for teachers, especially in the primary care setting, and also nurses and other allied professionals who are working in the nursing home setting for the reasons that we've already discussed.
Thank you. And it sounds like, I think, implicit from a lot of the comments, I just want to make sure I'm not misinterpreting it, is that the concern is around value assessment, that we want to make sure that these people have access. There have been arguments over the years about transmissibility, that we're concerned about vaccinating patients or children to protect nurses or teachers. It doesn't sound like that's the argument here. This is more about access for those vulnerable individuals to the vaccine.
Partly.
Right. So I'll answer for myself, which is that no, this is for primary support for these individuals to gain access to these therapies, um, and also because of the significant uncertainty related to transmission.
Thank you. Dr. Gold, does that cover yours? I want to make sure you have.
She covered me.
Okay, thank you. Okay, with that, I think we can proceed to vote. I just want to make sure. Any more comments from the subject matter experts or the patient experts or the clinical experts? All right, let's go to vote. So we batched those questions for presentation, but for voting, obviously, we need to do them sequentially. Okay, I'm seeing 13 votes, and I think we expect 14, right? Or is we have someone missing, so 13. Okay, so 10 typical obligations, 3 some added obligations, and 0 substantial added obligations. Great. Next question. So are there particular obligations because COVID-19 disproportionately affects those from a racial ethnic group that have not been equitably served by the healthcare system? Three votes so far. Five typical obligations, 7 some added obligations, and 1 substantial added obligations. Next question, please. Apart from issues around disease severity and unmet need and race and ethnicity, are there other particular obligations? So I guess the things that we've talked about here are socioeconomic factors. We've talked about professional vulnerabilities, referencing things around jobs and teachers. Those are some of the things that I heard in the conversation, at least. Ten votes, 11 votes. We have one more, waiting for one more. 13. So 3 typical obligations, 7 some added obligations, and 3 substantial added obligations. Let's move on to question 4. So like the prior 3, we will do 4 through 6 together. For all of these questions, the questions are meaning to apply to vaccination for COVID-19 for the 2026-2027 season. Again, making this different than any considerations for what COVID vaccine has been effective in the past and previous variants, previous points in sort of population level, um, immune phenomenon, like before people were infected and vaccinated and so on. So the first question um, is for adults 18 to 65 years old, excluding the younger men. Is the current evidence adequate to demonstrate that the net health benefit of vaccination is greater than that of no vaccination? The same question, but for a different population, children 5 to 18, again excluding uh, uh, older teenage boys 12 to 18. Is the current evidence adequate to demonstrate that the net health benefit of vaccination is greater than that of no vaccination? And the final one, or question 6, is the same question for children 2 to 5 years old. Maybe David, let's start with your findings just to remind us.
Sure. I'd suggest people look at figure 2 in the evidence packet, which shows the hospitalization rates in those groups. So we clustered these as groups at overall low risk and low risk of harm. So that's what this set of 3 is meant to be. The hospitalization rate for 2 to 4-year-olds is 20 per 100,000. For older children is 9 per 100,000. And then from 18 up to age 64 goes from 22 per 100,000 up to 80 per 100,000. So relatively low rates of serious infection, but this isn't the group that we had concerns on the harm side. And so if you looked at our evidence ratings, which are in table 3, these are all groups that we gave a C+ rating to for saying basically that we don't think there's a chance of harm and there's a chance of a small benefit, but that's the extent that we felt.
Questions or comments from the group, or again, any of our experts? Joe.
Thanks, Jason. I just want to confirm that the 18 to 65 group are healthy adults with no comorbidities, as opposed to the separate category that I see listed,
Yes.
people with Okay, just want to make sure.
Over this entire age range, it's meant to be no comorbidities.
Okay, just confirm.
Thank you. Dr. Winston.
Over the next several questions, obviously, we're being driven by the assessment of risk and the 2 parameters of number of vaccinations needed to prevent a hospitalization or to prevent death. It would help me if some of you that know could give us some context about those numbers needed to vaccinate with respect to other interventions so that we can think properly about that. I know they help drive the ICER rating, but could I hear from folks about that?
Really a question essentially about the magnitude of the effect. Dr. Huang?
I'm hoping Dr. Prosser can confirm this, but for the similar benefit from prior analyses, for other vaccines, the number needed to vaccinate is far lower for some. So, for example, the flu vaccine has, I see a wide range of different number needed to vaccinate, but it looks like it's around 70. So the numbers we're looking at here are in the thousands or hundreds.
The implication being that the
Proportions
treatment effect of this vaccine, that the magnitude of benefit is lower than
right.
Yeah.
Well, yeah, so I'm going to jump in and just say, the number needed to vaccinate, depends, of course, varies widely depending on what outcome is being referred to, and whether you're looking at total cases, which is not a very reliable NNV to look at because it's grouping together all of the possible outcomes, deaths, hospitalizations, and asymptomatic illness, symptomatic illness. I think if you look at the numbers compared to influenza vaccine, it's important to note, and this came up earlier in David's presentation, that the burden of COVID disease has been dropping substantially over the past 3 years, and that rates were actually quite similar. Looking specifically at hospitalizations, which I think is the most reliable metric, well, both hospitalizations and deaths, both for influenza and for COVID, in looking at disease burden. And in the last season, rates of hospitalization for COVID have actually dropped below flu. So if you looked at NNV, and the VE is actually very similar right now for looking at influenza vaccination and COVID vaccination. So I think I haven't looked at those specific numbers, but I would expect they would be very similar. And so, comparable at this point for the last couple of seasons and looking at flu and influenza, specifically talking about hospitalizations. And I think excluding, there will be discussion later about long COVID.
Thank you. It sort of feels like an absolute and relative effects issue in a sense that I guess if there's fewer hospitalizations because of COVID, the threshold to say that the vaccine is effective is different in an absolute sense, if I've interpreted this right. It's a very thoughtful point that you're making. Dr. Ross.
Joe is fine. For me, thank you. I feel like I'm at risk of either like exposing myself or embarrassing myself with this question, but it really just occurred to me as Stuart asked his, are we talking about a first vaccine to an otherwise unexposed person? And I apologize if I missed this, David. Or is this like another vaccine in the context of people either having been vaccinated or exposed before? And that's where I feel like much of the evidence that was presented, but I just want to confirm I'm thinking about this question correctly as we go forward with all of these.
Pretty sure it's population now. David, do you want to?
Yeah, it's a little tricky. The way we tried to think about this was a current US population. And even in people who haven't been vaccinated, almost all of them have experienced COVID antigens in some way. The groups that haven't had that are newborns, very clearly 6 to 12-month-olds, and probably also 1 to 2-year-olds who didn't get a vaccine during the 6 to 12 month. They're at risk of never having seen COVID and might see it for the first time. And we were more worried about them. If you knew that they had been vaccinated at 6 to 12 months, the amount that we think they need a vaccine at age 1 to 2 is lower than if they didn't get that. So it's not quite as clean as we'd like. Also, if they had COVID when they were age 6 to 12 months, it's different at age 1 to 2. But for almost everybody else, we just assumed that they've seen the COVID antigen in one way or another.
Thank you.
Other questions or comments including from experts? We would love to hear anything someone wants to chime in on this. And if not, I think we can proceed to these sequential votes. The first question, again, for adults 18 to 65 years old, and that's with all the qualifications that we've discussed already about contemporary time and exclusion of men 18 to 24. That'll be a vote later. Is the current evidence adequate to demonstrate the net health benefit of vaccination is greater than that of no vaccination? 7 votes. We're looking for 13. All right, we're at 13. So we have a split vote, 11 to 2. I hate to put people on the spot. Is anyone who wants to say no, want to speak up behind the logic? You certainly don't have to, but I want to give you an opportunity if you want. Joe, yeah.
Well, I voted no, and I admit that it's a close call given the lack of harms. I just felt like the evidence that I saw was so incremental at best that I didn't find it adequate. Again, it's a tough call, but that's where I sort of leaned.
Yeah, no, I mean, I'll self-disclose now that you said that I voted yes, but I follow your logic and share your logic. I think it is incremental and it becomes a little bit subjective about what we think is meaningful. Do others want to speak on this issue?
Yeah, I also voted Road with exactly same rationale that Dr. Rose shares. And then I also looking at compared to the other groups, like evidence that I've seen in other group that also kind of help me put in the context. If I just looking at evaluating only for this group, probably I would have voted a little bit differently. But again, that's kind of looking at all risk stratification perspective.
No, appreciate this articulation of the logic, because I think probably a lot of us agree, even if we voted differently on the underlying logic. Jim.
I agree with the logic that Joe and David and that you, Jason, described. And I thought the same thing. I voted yes. I'm going to be inclined to vote in favor of the vaccine because I continue to believe that the observation, the design of the observation, the key observational study understates the true benefits. So that leads me even more towards the voting yes in favor of the vaccine.
Yeah. Thank you for discussing all of this and sharing your logic for everyone. Let's move on to question 5. So this is the same question, but for different population. Children 5 to 18 years old, excluding boys 12 to 18, is the current evidence adequate to demonstrate that the net health benefit of vaccination is greater than that of no vaccination? And votes. We need 3 more. We're looking for 1 more vote. We have 12. Everyone's we got 13. Great. Okay, 10 yes and 3 no, and I'll spare putting people on the spot because I bet it's some of the same logic as we just went through for the other question. Next question, please, number 6. So same question, but just different population. Children 2 to 5 years old, is the current evidence adequate to demonstrate the net health benefit of vaccination greater than no vaccination? $13 votes, all right, 12 to 1. So I expect the same. We don't put people on the spot when there's only 1, but I suspect it's the same underlying logic as we just discussed. So next, we are moving to question 7, which is for the population of adults greater than 65 or greater years old. Is the current evidence adequate to demonstrate the net health benefit of vaccination greater than no vaccination? So maybe let's start with David, just summarizing the findings of the research team.
Right. So, as on the others, if we look on figure 2, people over 65 have a rate of hospitalization of 210 per 100,000, 75, 540, 85 plus 1,200 per 100,000. The VA study, we think, applies pretty exactly to this population, so that we applied both the effects in that on hospitalization and death. And we thought that there was certainly at least a small benefit and potentially a large benefit. I suspect that in 85 plus, there's almost certainly a large benefit compared with any chance of harm.
Thank you. Love to hear from the patient experts as well, the clinical experts, the content experts. Anyone who wants to weigh in on this? Professor Falk.
Yep. English, good too. David, I did think about your response before. So I'm not sure whether this is no comorbidities. I think it's average comorbidities. What do you think?
I think that's fair. Again, I find it really hard to sort this out. The number of 85-year-olds with no comorbidities is small. That said, I just want to say that I'm about to be doing a 150-mile bike ride over 2 days in a month, and you should all support me on this, despite my falling into this risk category.
Right.
Yes, we will be
And,
thinking about you, David.
and
Um,
we classified the elderly population as naturally immunocompromised when you get to that age.
yeah, that at some point having comorbidities becomes sort of a normal finding in a specific age group. Other comments or questions from the panel or from anyone? Dr. Wong.
Well, I mean, so, David is a 65-year-old, but, in every age group, there's a distribution of people with different rates of comorbidities, different levels of frailty. It just happens that as we get older, it shifts. And as we get better, with medical technology, those lines in the sand will keep shifting, as life expectancy gets longer. So what is considered older or what is considered a high risk group will shift. So it's not really just age itself, it's all the things that travel with aging.
To your point, as more people get more advanced imaging, the underlying definitions of what we consider comorbidities will change. Other questions? I'm just looking across the board. I don't think I see anyone. So let's, in that setting, go ahead to proceed to vote on question 7. Adults 65 or greater. So 13-0. So a remarkable consistency across our panel about the benefit of vaccination in this population. Next question, please. So this, again, is a slightly different population. For people under age 65 with chronic comorbidities, is the current evidence adequate to demonstrate the net health benefit of vaccination is greater than that of no vaccination? And we probably we're going to end up talking about this, but I want to be very clear about this, that the purposes of comorbidities, we're talking about cardiovascular disease, cerebrovascular disease, pulmonary disease, or chronic kidney disease. And to my recollection and my understanding, I apologize as a cardiologist, we're not talking about hypertension. We're talking about a history of myocardial infarction. We're talking about a history of stroke. We're talking about clinically evident COPD. Is that a fair summary, David?
That's the way we thought about it in the report. I mean, if you remember in the early days of COVID, the list of things you could have to count as being at increased risk was extremely broad. For the ones you just talked about, particularly cardiovascular comorbidities, it looked to us like they about doubled the risk. Again, it was not trivial to sort that out from how that related to age, and that CKD increased the risk by 50%, so not quite as much as the other ones. And, with that in mind, we gave this a rating of comparable or better, meaning we thought there was no chance of harm, possibility of a small benefit, possibility of a large benefit, as the range.
Comments or questions from anyone? We welcome input from experts or questions from the panel or comments from the panel. Not seeing any. Let's proceed to vote. See 9 votes, 13 votes. 13-0. So next question is, I think we're doing these ones individually. For children 6 to 12 months old, is the current evidence adequate to demonstrate the net health benefit of vaccination is greater than that of no vaccination? Would love David's summary of the research team's findings.
Yeah, so this is a group at high risk. If you look at figure 2, 6 to 12 months old, any antibodies you got from your mother are gone. You have an immune system now, so you can respond to a vaccine. The rates of hospitalization are higher than any group until you get to the 65-plus-year-old. So this is not a low-risk group in any sense. So we gave this group the B+ rating that I misdescribed, and Dan fortunately corrected during the talk, saying that we're sure there's at least a small benefit and there may be a large benefit.
Thank you. Comments or questions? I'm seeing everybody. I don't see anyone. Let's proceed to vote. $13 to 0. Let's move on to question 10. So this just really shifts the age a little bit. This is now children 1 to 2 years old. It's the same question we had before. David, do you want to summarize?
Yeah, so here, the risk that you see in the population in figure 2 is similar to that in people aged 50 to 65. But as Joe was sort of asking about, and I was being nervous about because we don't know how quite to think about this, some of these children won't have received a vaccine at age 6 to 12 months and won't have gotten infected with COVID between 6 to 12 months, which means potentially that their immune system has never seen the COVID antigen. At least one or two experts said to us, the first time you see the COVID antigen, it should be a vaccine. And that my ability to tell you that that's 100% true is limited, but I don't think that's a crazy way to think about these things. We ultimately gave this a C++ rating. The fact that people believe that doesn't make it certainly true, but we certainly don't think it's harmful, and there may be a large benefit to vaccinating at age 1 to 2. So we gave this a comparable, incremental or better.
David, I recognize it's probably hard to know, but did you get any sense through your research of a period of time that, like, what general proportion are we talking about amongst these that are 1 to 2 that have both not received a vaccine when they were younger and not gotten infected? I mean, I know it's hard to know, but like, is there
It's worse than that because it's changing constantly, right? I mean, rates are coming down like this. So and then there are waves coming through, and it's when you're born, and was COVID circulating while you still had maternal antibodies, but then not circulating the next 6 months?
Really
don't know.
Really hard to know. Okay. No, thank you. I guess it's probably season, like if your summer birthday, a winter birthday is probably very influential there.
Right. Malcolm Gladwell could write about this.
Thank you. Yes, that's a great idea. Maybe an idea for a regression discontinuity research project in the future. Questions or comments? Okay, let's proceed to vote. $12 votes, waiting for one more. 13 to 0. Let's move to 11. So this is relative to women who are pregnant. Is the current evidence adequate to demonstrate the net health benefit of vaccination is greater than that of no vaccination? David, do you want to remind us the findings?
Yeah, and so one thing I'd say about this one is actually two things I want to say. First, we're talking about third trimester vaccination, and we're talking about benefits both to the pregnant woman and to the newborn. There's been lots of worry constantly on the harm side about vaccines during pregnancy. You could imagine that a COVID vaccine that causes fever during organogenesis, we have animal models that suggest fever is bad during organogenesis. That happens very early in the first trimester. So by the third trimester, we don't have any reason to think that running a fever for a day or two from an mRNA vaccine is teratogenic or in any other way harmful to the fetus. We know as we described, that newborns, if you look at trying to get back to figure 2 here so I can quote you a correct number. That at less than 6 months, you're seeing hospitalization rates of 250 per 100,000, which is higher than anything until you get to 75 and older. So an extremely high risk group. Our evidence that it's beneficial is biologic plausibility. This is not high quality evidence, but we have lots of other vaccines that have shown benefit in this situation, and vaccines early in the pandemic that showed benefit in this situation. And pregnant women are at increased risk. The risks are not tremendously high, but they're higher than in comparable aged women who are not pregnant. So there's a benefit there as well. And we felt that this was a group that we were willing to say the benefits were at least small and might be large, and that we did not think there was a possibility of no benefit or that they were harmful. I will note that this does not match current labeling.
And what was the evidence rating with that conclusion?
That's a B plus. That was a B plus rating.
B plus.
This was one of the 3 groups we gave the highest rating to.
And it doesn't match which current clinical recommendation?
The FDA, remember,
changed
about a year ago, withdrew some of the indications, and the indication does not include vaccine during pregnancy right now.
So it did, but it doesn't now. It's changed, it sounds like.
I think that's right. Yes.
Yeah, that's my recollection as well.
But ACOG is recommending it.
Yes.
Yeah, so it's worth pointing out to the panel that this is an area where there's potential discordance of recommendations. Do people have questions or comments about this? Any comments from the experts too? All right, let's go ahead to vote. $11 votes in. We need 2 more. We're almost there at 13. 13-0. Wow. So unanimous. Let's move on to question 12. So this is a specific subpopulation that includes both young male adults and older male children between 12 and 24 years old, where the conceptual issue around myocarditis has been raised. Is the current evidence adequate to demonstrate the net health benefit of vaccination is greater than that of no vaccination? Let's start with David's summary of the research findings.
So we can start on the benefits side. This is a group that gets small benefit. There's a healthy young population that is at very low risk from COVID. I want to read the definition of our promising but inconclusive rating so that people hear the wording, because the wording you're voting on is not the same. And I want you to know that as you're thinking about it, so you can understand how we would give a PI rating, but you might or might not match that in the way you're voting. So a PI rating is moderate certainty of a small or substantial net health benefit, small likelihood of a negative net health benefit. So we would have to be certain that there couldn't be a negative net health benefit to give a rating higher than PI. That's in the way we think about this, we'd have to be sure. Let's go look at the vote now, Chloe.
At the voting question?
Yeah, I just want people seeing the voting question. Is the current evidence adequate to demonstrate that the net health benefit? So those are not exactly the same question. And I point that out just so that nobody feels bad if they feel they want to vote differently from the way I rated this, because they're not exactly the same. Ingvar.
Just a quick question. So the evidence that when we looked at it, and I would like to just comment on that, was much stronger for any relationship when we had multiple series of closely spaced injections, rather than a single injection that we now see with the yearly ones. In addition, obviously, we had to deal with rates initially, and we did not know what the baseline risk was in the general population. And the only way to actually understand whether there could ever be a net benefit, a net negative benefit, would be to know whether that rate, that background rate, exceeds the rate within vaccination. And so, again, I would love to hear your thoughts on those
Sure.
issues.
So there are a few things there. One is it might be that the closely spaced vaccines was the problem, but that isn't the only thing that's changed since the time of the closely spaced vaccines. Maybe it's that everybody has seen the antigen and that's the difference, or the strains changed, or something else. So the closely spaced vaccines is many people's favorite explanation for what changed, and they may well be correct. I don't know that we can know that with certainty. So I just want to be uncertain that that's the right explanation. On the harm side, I think people sometimes say, well, the rate of myocarditis after COVID is higher than the rate of myocarditis after vaccine. And that gets tricky because if you're giving tons of vaccine to a whole bunch of people who are exceptionally low risk of ever having COVID clinically significant enough to get myocarditis from, that's a hard comparison. That doesn't mean that couldn't turn out to be a true comparison. But we don't know right now we don't know either side of this perfectly. All that said, my guess is that the COVID vaccine is pretty safe in young men and teenage boys and is neither very beneficial nor very harmful. When people ask me clinically, how strongly do you feel about this? I'm like, I'm pretty sure you can't make a bad choice one way or the other. I just don't feel very strongly that we know perfectly the answer to this question. Does that get where you were going, Ingva? Okay.
Rena, Professor Conti. Oh, I think we
You're on mute.
Her. Yeah.
Thank you. Also, Rena is perfect for me. Thank you. I have a follow-up to the same question, which is, again, it seems to me that the concerns about both immunogenicity and also myocarditis, or however you say it, is the burden of the companies themselves to address over time. And also one that seems like there should be extra scrutiny on by the FDA review committees who are reviewing these vaccines over time. And so again, I'm going to ask my first question again, which is, does anyone here have a sense of how the evidence base on both of these issues has changed over the lifetime of these products?
I think we're pretty certain that in 2020, these vaccines were causing myocarditis at an increased rate, occasionally significant enough to get people hospitalized, particularly in younger males. And that since then, the rates look like the background rates of myocarditis. So at some level, that's how the evidence has changed. And everything else is the story that you tell for why the rates did that. Lisa, you have a better answer on that? Maybe?
No, I do not have a better answer, but to add to that, there is some, concern around these data that there has been an observed attenuation in potentially associated rates events of myocarditis in vaccinated individuals, males within that age range. But at the same time, the numbers are so small that if you look at the coverage rates, across all of our age and and demographics, that there is very, very low vaccination within that group because of, understandably, the initial concern around those adverse events, and then the FDA labeling that highlighted those events in that risk of those events in that particular age group. So there has been an attenuation, but again, it's small numbers, and so there's concern that it's simply because those individuals are not getting vaccinated. So it's hard to say.
What is the ballpark proportion of vaccination in that? I realize I'm asking another unanswerable question, but just are we talking about like 10% or?
I'll jump in. I think it was in the low teens. Lisa, you can correct me. For under 18, I believe the most recent season was about 20% of the overall population, about 45% of the 65 plus, and I think it was in the 12 to 14 range for the overall pediatric population. Is that about right?
I think it's even lower than that now. I think it may have dropped below even 10% for and
The
teens.
vast majority, it sounds like the vast majority are already opting out.
Right, exactly.
Dr. Gold? Oh, I think you're on mute.
I've been thinking about this as a shared decision-making issue, and so I just want to let you know that this is sort of what is going to influence my vote.
Do you want to say more? Just maybe influence the panel, because I think this is going to be.
Yeah, well, I think that I would like to err on the side of this being available to this population, and that there can be discussions in the clinician-patient exam room as to how people want to weigh the risks and benefits. So that is very influential to how I think about how I'm going to answer the question.
And that kind of comment is something that could go into the policy recs too. That's another.
Yeah. I'm sorry if I jumped the gun.
No, not at all. I just getting it on the record. Jason.
Yeah, I just wanted to add one follow-up to Rena's comment about sort of what the FDA is doing. They did update the labels to mention these risks, as Dr. Prosser noted. The other thing that was noted in those announcements was that the manufacturers of the approved COVID vaccines were required to do studies looking at long-term risks of those myocarditis cases, as David mentioned at the start of the day. As far as I understand, the vast majority of these cases of myocarditis did not have long-term adverse consequences, but the manufacturers are required, active present tense, to do those studies. But the last I saw, they were underway without results on that regard. So it's those short-term safety monitoring systems that continue to give us the best signals of the cases there. But in terms of any long-term things, FDA is still looking for those studies from the manufacturers, to the best I understand.
So I would speculate totally that trials are almost impossible in this setting with such a small effect. And then observational data probably pretty difficult too, if so many people, as Dr. Prosser has articulated, as opting out of the vaccine. It's going to be hard to even address this with observational data. I think this is not going to be a 13-0 vote, so I just want to make sure everyone has a chance to talk and say things if they want to. Dr. Cooper, go ahead.
David, could you repeat, now that we've heard all these comments, could you please repeat the definition of the PI rating?
Sure. I'm like scrolling back to it so I say it correctly, but the easy way to think about it is to get to a C++ or a C+, this would be a C+ if it wasn't a PI. To be a C+, we would have to be certain there was not net harm. So that's sort of the distinction between those ratings of a comparable or better means we're sure there's not net harm, and that with a PI, we're including the possibility that there could be harm, like scrolling around trying to get, I see my problem here. Here we go. Moderate certainty of a smaller substantial net health benefit, small likelihood of a negative net health benefit. So that's how, and that you don't have to view there. It's a rating. We can think about it different ways, but the way we thought about it was we are not certain that the benefit isn't negative. That was our ultimate conclusion, that there might be benefit, they might be neither benefit nor harm on net, or there might be a small chance of net harm.
We'll move to voting unless anyone else wants to say anything or ask questions. Nine votes, waiting for three now, more, 10, 12, one more. 13 votes. All right, 6-7. Wow. Yeah, very split vote. I won't belabor the issues because I think we had a really good conversation about that. I was sort of anticipating more split votes. So I think it was nice to have the discussion to sort of encapsulate some of the controversies and the issues and the unresolved issues in this question. Let's move on to the next question. Just question 13. Now, this is about the differences between the vaccines. Is the current available evidence adequate to distinguish the net health benefit among Comirnaty, Spikevax, and Spike and Nuvaxovid? David, do you want to say, hopefully I pronounced them all right. I'm not sure I did, even though I did get training on that this morning. So my apologies if I did.
No, I'm feeling bad. I told you all that you were never going to actually have to say the names of the
that is correct.
The mRNA or the protein. But I think we know from the early in the pandemic, if you look at the rates of minor harms, that there were clearly higher with the mRNA vaccine than with the protein-based predecessor of Nuvaxovid, which was Novavax. We actually have some recent, some published, some unpublished recent data showing that there's still some more minor harms from at least one of the mRNA vaccines than from the protein-based vaccine. So if that's all you had to look at, the answer would be you can distinguish. The protein-based vaccine has less harms. However, we don't know that it has equal efficacy. We don't know that its efficacy is the same as the mRNA vaccines, better, worse. We don't know among the 3 mRNA vaccines perfectly whether one of them might be more efficacious than the other 2. And that's obviously incredibly important. I mean, if you're going to be vaccinating an entire population, if one of them provides 92% protection and another provides 94% protection, that's actually a really important fact. If one of the vaccines provides, as in the VA study, 28% protection, but another one would provide 31 and another one would provide 25, that would overwhelm probably the reactogenicity issue, and that led us to a rating of I. Without head-to-head randomized trials, we don't think we can answer this.
And are there conceptually like clinical conditions that would make you want one mechanism versus the other, like to take that trade-off between efficacy and side effects?
So there are people who, whether this is fair or not, you encounter people with autoimmune conditions and doctors of people with autoimmune conditions who worry about the implications of a vaccine that causes a big immune response, like the mRNA vaccines. And so sometimes I've had patients tell me their immunologists or rheumatologists don't want them getting either any COVID vaccine or one of the mRNA vaccines. I don't think we have any decent data on that, but that doesn't mean that's not there. I think the most common situation is a patient coming into a primary care doctor like me and saying, and by the way, I'm one of the patients who comes into a primary care doctor like me saying this, there's no way in hell I'm getting another mRNA vaccine and being sick for 2 days, but I'm willing to get a protein-based vaccine because the last time I got it, I was only sick for about 4 hours. So I think that's the most common situation. And you get other people who say, I've gotten mRNA vaccine year after year after year, and it doesn't bother me at all. And why wouldn't I keep getting it? And at this point, a lot of people already know whether they're bothered by the mRNA vaccine. So as a primary care doctor, switching from my evidence role to my primary care doctor expert role, I tell people who tell me they won't get a COVID vaccine next year because of how much it made them feel sick to just try the protein vaccine once and see how they do with that.
Yeah, no, totally valid. Makes sense. Do the experts want to say anything about this? This is really about distinguishing. And if we vote that we can't distinguish them, then we'll not do the other votes. But if the panel votes that we can tell the difference, we have to take sequential votes on the different comparisons. Does anyone want to say anything about this or ask questions? Just make sure I'm seeing everyone. Let's proceed to vote. Is the current available evidence adequate to distinguish between the net health benefit of these 4 options? Uh, 13 no, 0 yes, so we will not do the individual votes on the individual comparisons. And instead, we will move to question about benefits beyond health. And the first one is to inform judgments of overall long-term value for money. Is vaccination likely to improve caregivers? And we had a question, Omar had a point about this earlier. Caregivers' quality of life or ability to pursue their own education, work, and family life. Maybe we'll start with David with Dr. Rind about the findings of the research team.
Yeah. So again, this isn't exactly about vaccinating the caregiver. This is about vaccinating somebody who might get sick and somebody would have to care for them. And our sense was that on average across the population, to the extent we're talking about caregivers' ability to pursue their own goals in life, education, work, family life, their long-term quality of life, that the number of people who would be benefited by vaccinating somebody else to have that experience as a caregiver is extremely small. And we didn't think this was a big deal for this vaccine. That said, you can all imagine situations in which that would turn out not to be the case, where somebody could have an overwhelmingly bad case of COVID, land in the ICU on a ventilator for months, where the caregiver is going in, and then the person comes home and they're rehabbing. There are all those things you could imagine, but they're really, really uncommon in 2026. So I will leave it to all of you to decide how you think about that. I actually think you all have all the evidence you need to think about it. There's nothing special I have in this space to help you think about this.
Dr. Escontreras, do you want to say any more about this? Because I know you had referenced this earlier.
No, thank you for clarifying, Dr. Rand. I think that's very helpful for us for members to make a decision on this. I just wanted to make sure that perspective of the caregiver wasn't missed, as was included in the report, and I think it was very important for it to be included. So I just wanted to make sure that was highlighted.
No, for sure. Yeah, absolutely agree. Absolutely agree. Anyone want to say anything else? We move to a vote. Let's move to a vote. Is vaccination likely to improve caregivers' quality of life, as we just discussed the definition of, or ability to pursue their own education, work, and family life? I have 10 votes, 11, 12, 13 votes. No was 10 votes, and then there's a small improvement for 3 votes and none substantial improvement. Next question, please. So this now integrates a lot of the economic considerations and this long-term value for money. So next question, given the available evidence on comparative clinical effectiveness, a lot of the questions we've just considered, and incremental cost effectiveness, and considering some of the other factors that we've deliberated on, benefits beyond health and special ethical priorities, what is the long-term value for money currently available vaccines for COVID-19 compared to no vaccination at current pricing? And so we would love to hear, I think, from Professor McQueen. I can't see him on the board. Oh, here he is.
Yeah, I'm here.
Hey.
Yeah, I think you're gonna, in the evidence summary, you're gonna look at the cost effectiveness section starting on page 11, table 10. So remember that that's the pooled result across all the high risk age groups, with, of course, the heavier weight being the 50 years and older, with the highest number being in that 65 plus. You actually can see those numbers in the footnote if that's helpful for your decision. We did talk a little bit about we have a very small increase in cost and a very small increase in benefit that shows up in table 11 for the incremental results. Some of the other information that might be helpful, figure 4 is the one-way sensitivity analysis, which really kind of gives you an idea of probability of hospitalization being a big driver. And then after that, you have the probabilistic and then the scenario analyses, which we've had a couple of people comment. I know Dr. Kim also mentioned scenario 3, which I did not point out in the presentation. It's a very important one also to consider. So with that, happy to answer any questions.
Questions from the panel for Brett.
Okay, I feel obligated to ask. So, Brett, these are way more cost effective than most things ICER looks at, right?
I don't not necessarily. I mean, I've done a number of reviews that have been cost effective. I guess the most recent one, maybe I shouldn't give you an example, David, but yes, these are pretty cost effective. I think the most unique part about this is that we don't see huge benefits and huge cost offsets. We're really talking about really small changes in both the numerator and denominator.
So it's like totally different than a new cancer drug that may
Exactly.
actually have a pretty big benefit, but be $1 million a year. It's a different situation, although we're trying to use the same ratio principle.
Exactly.
Professor Rippetson.
Hi there. At the risk of repeating myself, I want to return to the point I made earlier, and it's an economics point more than a clinical point. And my apologies if it's boring or irrelevant for that reason. But when you think about long term in an economic context, what you really are thinking about is a time period long enough that the system can respond and reduce or mitigate choke points, capacity utilization constraints, that kind of thing. And when you're talking about, and this relates a little bit perhaps to the infectious problem, but I don't think it really does. When you're talking about a contagious disease that occurs in seasonal waves, right? If you could reduce the size of those waves, the opportunities for gains to the system can be quite substantial. And for that reason, Brett mentioned before that they don't exactly model that, and that's fine. It's a hard thing to think about how to model, but it makes me think that when you're thinking about the long-term economic gains here, that we're kind of the incremental cost effectiveness framework is kind of underselling what a vaccine technology can offer economically. And I just wanted to sort of repeat that point because and hear people's response to it.
And if I can chime in and just say, I think where you're going with this, and maybe I'm at risk of saying something you don't mean here, but it's almost like you're looking at the hospital perspective, almost like return on investment of vaccines, which is a different perspective than the whole health system, which is really what we're doing. So I think some of this has to do a little bit with perspective. Capacity would be built into that return on investment. That's where I'm going with this is a hospital will do that return on investment calculation, potentially even investing in their own, like a system, think of like Kaiser Permanente, which they're doing these calculations, but from their perspective. We're really looking at this from the entire health system and everyone involved that you would be eligible for screening, which is that high risk group. But I do think like capacity constraints, I agree with you. It's not totally included in the cost offsets. And that might be an underestimate of the benefit of vaccines from those different perspectives. So I think it's really.
If I could just follow up on that, you're right that I am thinking about it organizationally, but I think that's not different from thinking about it from a social perspective. Because from the social perspective, you do have to think about investing to deal with peak capacity. If you don't, you pay a really big price. right? And so it's like batteries. It's like adding batteries to an electrical grid, right? You don't have to sort of build up a grid that handles such huge capacities. I'm thinking about the capacity constraints here are things like ICU beds during waves of respiratory viruses, that kind of thing.
Yeah.
So it is organizational. I can't help it. That's kind of how I am. But it's also social.
Yeah.
They're not, Jim, I'm just reflecting. I mean, hospitals have planned for seasonal variations in respiratory illness in beds, ICU capacity for many, many years. I guess I will say that also that I heard from Dr. Prosser that hospitalization from COVID is relatively low, compared to other illnesses, if I remember the conversation correctly. So I also wonder, even if that is an effect, how much of an effect that is. I mean, very different situation than April 2020 when we were worried about running out of ventilators and stuff. Dr.
That's a
Prosser,
really
is that
important
an accurate
response.
reflection of what you had said before?
I think that's a really good response, right? A lot depends on how much you think availability of the vaccine can shave off these seasonal waves.
Joe?
Thanks. I just wanted to ask another clarifying question, sort of in response to David's comments. Obviously, these estimates are very cost effective based on typical things we see. But I wanted to confirm, just to be 100% certain, these estimates are based on the benefits, costs and benefits estimated for those 65 and up and those under 64 with comorbidities. I'm only asking for that clarification as I was in the minority among the group, right? We're not being asked to differentiate this estimate by population group, and I was in the minority in terms of my confidence in the adequacy of evidence.
You have it correct the way you described it. Yep.
Dr. Prosser?
Great, thanks. I just wanted to highlight a couple of aspects of this analysis. One is that, different from other conditions that, in economic modeling we're typically dealing with, that we may have a new intervention, but, it's very rare that the disease itself is new. And so while there may be uncertainty around the effectiveness of the intervention, we typically have, often decades of evidence on the burden of disease that we're using to parameterize the model. And so I think it's important to recognize the uncertainty that is involved in modeling COVID, both from the burden as well as from effectiveness of evidence. And in that light, it's important to keep in mind all of the uncertainty analysis and the scenario analyses that have been done for this particular question and how robust those are to changes in the underlying parameters and in the different scenarios. The second point that I think is important to keep in mind is that in the context, and again, I think this will likely be more of a discussion, in the policy roundtable, but that there are various recommendations that are, at play here in the United States right now. And so this base case analysis essentially models the FDA labeling, so a high risk recommendation. Whereas, other clinical groups and professional groups are recommending, are essentially endorsing the prior ACIP recommendation, which is a vaccination for everyone 6 months and older, and which aligns, somewhat with, the current ACIP recommendation, which is kind of an individual decision-making recommendation, Martha, you had brought up before. And just to highlight that scenario analysis 6 is the scenario that models vaccination of all individuals. And so it would be consistent with that if that is, what you're considering when you're thinking about this question.
Thank you. Dr. Kim.
Yeah, I had exactly same questions as Dr. Rose, and related to that, this is related to voting questions. So because voting question didn't really specify specific target populations that we are considering. So I'm a little bit confused that are we going to vote on long-term value for money among current available vaccines to no vaccinations at current prices for high risk 6 months to 65 and everyone 65 plus, which is what the main evidence presented versus the, kind of everyone. So kind of Lisa point out the kind of scenario 6 I'll just like to get a clarifications on that.
Yeah, I'm not sure if I should be the one weighing in on this, but I read this as to mean everybody. Um, but if anyone disagrees, I'd love to hear that now.
I would just say that the base case analysis that Brett did was the FDA label. So at some extent, we were picturing it as what's the cost effectiveness under the FDA label.
But I think people should feel free to think about the range of results between that base case assumption and scenario 6, as Lisa said.
And I will add that this voting question is meant to be informed by more than just the cost effectiveness results. And it's informed by the special ethical priorities, the benefits beyond health. So keep that in mind as you're voting as well, because it's meant to represent your judgment of the comparative value given not just the cost effectiveness, but these other benefits that we've been talking about today.
And David, can I just ask that, so to the extent that the base case model is based on the FDA label, is that to say that the base case excludes populations for which the FDA label doesn't include a recommendation to get the vaccine now? The FDA label doesn't include a recommendation to get the vaccine now?
That's correct. Sorry, I'm not David, but I'll respond.
No, please.
So Brett and team assumed that individuals outside the label did not get vaccinated.
Got
it. Just to point out, in terms of how you all voted and everything else, the main place that it looks not like the FDA label. So if you think about where we thought, and you all ultimately thought in your votes, that the evidence was really good, that looks different somewhat from the FDA label, it's in young children and pregnant women, which won't have a huge effect on the cost effectiveness. What would have a big effect on the cost effectiveness is if you start vaccinating everybody from age 2 to 65 who are healthy. So, the FDA label, if you were ICER, neither the current FDA label nor the prior ACIP recommendation exactly matches where we think the evidence falls right now.
Yeah. Dr. Gold, and then we'll go to the vote.
I just want to ask Sarah a question because she just talked about thinking about everything in terms of long-term value, but it also says at current pricing.
Yep.
And so that to me changes a little bit how I might think about this, because if I believed that this was a social good, that I wanted everybody to get this, and I thought about the budget impact of everybody getting this vaccine, I might think that I would want the price to be lower. So I wonder if you could comment on that.
We very intentionally do not include budget impact in our vote of long-term value to sort of skirt that question, Martha. So I think I hear you, but it's not meant to be a recommendation about vaccination or not, right? So that's sort of social good and wanting a lower price. It's meant to send a signal of whether or not we think the price picked by the manufacturer is fair, given what we know about the benefits. And so I think of it separate from that budget impact or separate from a policy choice we might want to make about better access with an even lower price. It's probably an unsatisfying answer. I also invite Dan or anyone else who wants to chime in.
Yeah, I mean, can everybody hear me okay, first of all?
We're getting a fun echo every time you unmute, but we can hear you.
Maybe. Okay.
We're getting a fun echo every time you unmute, but we can hear you.
I even put echo cancellation on. I'm sorry. Okay, I'm canceling myself. Anyway, I'll try to speak quickly, but so long ago, Martha, we had directly integrated budget impact considerations into our assessment of value, but we also found ourselves in the situation that we were then considering highly cost-effective treatments of dubious value because of the budget impact implications. So direct-acting antivirals for hepatitis C, for example. It's really not a measurement of value. It's a measure of a signal, as Sarah mentioned, to the health system that whatever benefit is being considered should be managed in some way. That could include additional price negotiations, but could also include prioritizing populations, what have you. So we now consciously think about the value, the long-term value for money, separately from the shorter-term budget impact.
Thank you both.
Thank you. Let's proceed to a vote. See, 5 people already voted.
Oh dear.
Waiting for 4 more. One more vote. 5 high long-term value for money at current pricing, 7 intermediate long-term value for money at current pricing, and 1 low long-term value for money at current pricing. And with that, I think we just took all the votes. I honestly was a little bit apprehensive when Lise Hinsberg and Sarah asked me to come out of retirement to do something very controversial and complicated thing with lots of questions, but I'm tremendously grateful for ICER and for all of you for like an incredibly thoughtful discussion, bring everyone in the room. Some of us didn't totally see the data the same way, but we discussed it. A lot of us had more commonalities than even the votes would indicate. So I'm tremendously grateful for that process. I think that at a time of mistrust, it's important to restore trust. And one way we can do that is to discuss, debate, have open dialogue, and respect each other's views. So I'm grateful to be part of that process. We will have a break and resume for the policy roundtable at 2:10 p.m.